Hey, ladies and gentlemen, HIPECtreatment.com would like to welcome you to this HIPEC Facebook Live presentation entitled HIPEC plus Cytoreductive Surgery for Peritoneal Metastases Past, Present, and Future. At this time, it is my pleasure to present Dr. Kevin Sullivan, Medical Director of the Peritoneal Surface Malignancy Program at University of New Orleans, Louisiana.
Thanks, Glenn. Thanks for that introduction, and thanks to everybody for being here to learn a little bit more about HIPEC surgery. And I wanted to take the opportunity to sort of talk about a little bit about where the idea for this kind of surgery for this disease came from, where it's led us to, and where we're at today. And then some of my thoughts and things about future directions. And I see a lot of them for taking care of patients with this disease. And so I'm excited to kind of present some of the next steps and hopefully the things that we can do to move the needle in the future. Like Glenn said, I'm Dr. Sullivan. I work at LSU and primarily out of University Medical Center in New Orleans. I'm a surgical oncologist, and so the focus of this talk is going to be about GI peritoneal metastases, and particularly some of the more common ones. That is not to say that there are other indications or that this is going to be all-inclusive, but these are some of the more some of the more common diseases that metastasize to the peritoneum. So with that being said, I think we'll get started. So to get started, I wanted to lay a little bit of groundwork for those of you who may not know exactly what the peritoneum is or what metastases to the peritoneum are. I think it makes a little bit more intuitive sense when we say that cancer has spread to the liver or the lung or another organ like that, but a lot of folks haven't necessarily heard about the peritoneum before. And so what the peritoneum is that's the cavity, the abdominal cavity, where all the abdominal organs kind of reside in. You can see in this picture, it's a space where the different organs like the liver and the stomach and the intestines are, and they're attached to the blood supply in the back. And the cavity is lined with a sheet of cells that are called the peritoneum. The peritoneum also covers many of these intra-abdominal organs. And so the analogy that I use is if the abdominal cavity is like a room, the peritoneum is like the wallpaper lining the walls, or maybe the fabric covering the sofa, if your sofa is one of the organs that resides within the abdominal cavity. And so what happens when cancer spreads from other organs, two of the more common ones are the stomach or the colon, and it kind of sticks to the wall. It sticks to that wallpaper of the peritoneum, or maybe to that fabric of the sofa, like I said. So that's when cancer has metastasized or spread to the peritoneum. There is a somewhat more rare tumor or cancer of the peritoneum, and that's called peritoneal mesothelioma. That's where the peritoneal lining, the cells themselves, become cancerous. You may have seen commercials for lung mesothelioma after asbestos, and it's kind of somewhat related to that, although separate because it's in the abdomen and not in the lung, and it's not really related to asbestos. So that's kind of what that is. Why does it happen, especially when things metastasize from their organ to the peritoneum? Well, there's a couple of different ways that we think that happens. The first is what we call direct invasion. So if there's a tumor in the stomach that makes its way up through all the walls of the stomach and kind of bursts out, that can allow the cells to implant on the peritoneum. Another way is the peritoneum has a lymphatic system. It has things that we call milky spots that are kind of the lymph nodes of the peritoneum, so to speak. And so some of these tumors transmit via the lymphatics and can get access to the lymphatic system in the peritoneum and spread that way. Somewhat similarly, sometimes cancer can gain the ability to access the bloodstream and spread via the bloodstream. And so the peritoneum does have some access to some blood vessels in the bloodstream, and so cancer could spread that way. And then everybody, has fluid in their peritoneum to a small degree, and that helps kind of lubricate things so they don't stick and the intestines can move around and shift and get food through it. And so via that fluid that is kind of usually at equilibrium going back and forth between the rest of the body and the peritoneum, some cancer cells can shed and get into the peritoneum that way. One of the challenges, I think, in treating this disease, peritoneal metastases, is that many of our systemic chemotherapies, so chemotherapy that goes into an IV and travels in the bloodstream throughout the entire body, doesn't quite have access to the peritoneum the same way it does in the liver or the lung. The liver and the lung have a lot of blood vessels and a rich blood supply that brings blood through there to detoxify things in the liver or get oxygen in the lungs. But the peritoneum is a little bit sequestered. There's not as many blood vessels that go directly through it. And so we think there's kind of like a peritoneal plasma barrier that limits the penetration of some of this chemotherapy and may not make the chemotherapy as effective for metastases to the peritoneum. And these were a couple of studies of different chemotherapy drugs for colon cancer in patients that had metastatic colon cancer. They were called Cairo and Cairo 2, and they were looking at different chemotherapies. And when these researchers went back and looked at all the patients and separated them into whether they had peritoneal metastases or metastases to other places, the patients with peritoneal metastases, those in red here, had worse survival. They did worse than the patients that did not, and that's in blue. And we think that's potentially or probably related to the lack of access to chemotherapy, that lack of that rich blood supply, that the chemotherapy in the IV doesn't quite get to the peritoneum and penetrate and affect these tumors as much. So how often do some of these peritoneal metastases happen? I mentioned I'm going to comment on kind of colon cancer and gastric or stomach cancer as two of the more common ones. So this is patients presenting with colorectal cancer, colon or rectal cancer, and about 1 in 5 have metastatic disease. And a little over half of those have metastases to the liver. A small percentage only have metastasis to the lung. And then about a quarter have metastases to the peritoneum when they're diagnosed. And about half are only in the, little less than half are only in the peritoneum, while a little over half have the peritoneum in other site. And so that's just a diagnosis, but obviously peritoneal metastases could happen even after a curative resection of the colon. And so that gives a sense of kind of how often this happens in colon cancer. And this is all important of where things are metastasized, because there seems to be a prognostic impact based on where the metastases are. You can see this blue line. These patients have the best survival. When things are shifted to the right, that's a longer survival. So patients with lung metastases seem to do the best. Liver's in the middle, and then kind of like we mentioned earlier, the peritoneal metastases have a worse survival compared to the other two. So for colon cancer, I mentioned we're going to talk a little bit of history of intraperitoneal therapy. And interestingly, the very first instance that I could find of somebody using therapy directly into the peritoneum as opposed to IVs, chemotherapy, or IV medications and things like that was this English surgeon, Christopher Warwick. He had a patient with severe ascites or fluid on the abdomen, and used something called Bristol water and then actually a Bordeaux wine, and treated the patient for the fluid, the ascites, the fluid in the abdomen for that. And that's the first time that I could find that anybody had ever heard of that. I don't know that it bore out because that never became a popular treatment. But in the kind of the 70s, people started doing, kind of resurrected this idea, at least, of, it's hard to get chemotherapy to the peritoneum, so maybe we can deliver it directly to those surfaces, kind of like spraying down the walls of the room, to use that analogy. And so the very first report of essentially HIPEC, so thermal chemotherapy with a machine to perfuse that chemotherapy and keep it warm, for cancers of the peritoneum and the serosal surfaces. That was done for an appendix mucinous tumor by a Dr. Spratt et al. In the 1980s. And so the experience built on that, with Dr. Sugarbaker being a pioneer for cytoreduction and HIPEC kind of throughout the 80s, and showing that it could be done safely, and showing, at least in his experience, some good results. And so that led to a randomized controlled trial. These are generally our kind of gold standards for determining whether a treatment works or is better than other treatments or not. And this was done in the Netherlands, a randomized controlled trial for colorectal cancer that showed that compared to the standard treatment at the time, this is like kind of late 90s, it was published in 2003, compared to the standard treatment at the time, the patients that had cytoreduction and HIPEC had a longer survival. And so that really, I think, opened up the field essentially and kind of revolutionized the way that we could view peritoneal metastases. We developed a scoring system to try to quantify the amount of disease. It's called the Peritoneal Carcinomatosis Index, or PCI. The abdomen's divided up and the intestines are divided up into a total of 13 different sections, and then we score them based on a little bit of no tumor or a little bit of tumor to higher amounts of tumor, and a low burden of disease is a low PCI, so in the single digits, and then it goes up into the 30s is a high PCI. So that was for colorectal. A lot of that was data for colorectal cancer, but gastric cancer also has a propensity to seem to metastasize to the peritoneum. So gastric cancer in general is the 5th most common cause of cancer in the world. And I showed the statistics for peritoneal metastases for colon at diagnosis, but a higher percentage, upwards of 40% of patients with stomach cancer have peritoneal metastases at diagnosis. And as I mentioned with colon cancer, it can recur or come back in the peritoneum even after a curative surgery for stomach cancer. Some studies show as high as about 50% of the time. So this is a significant problem for stomach cancer as well. And so when I think of kind of looking back at some of that history and what the issue is, what are our goals of regional therapy? It's actually two-pronged. The surgery consists of kind of two different parts. The first part of this is this cytoreductive surgery, or often abbreviated CRS. And that's removal of all visible tumors that we can kind of see with our eyes in the operating room. The second part is the HIPEC surgery. So that's the HIPEC part, and that's the warm chemotherapy perfusion. We use a pump that keeps it warm and kind of lets the chemotherapy solution bathe through the abdominal cavity, so that to try to access all of the compartments and kind of in between organs and things like that. And so that's really used for the goal of that is basically for cells that we can't see with our eyes. Sometimes there's fluid in the abdomen and there's cells that are floating around and we just can't, they're too small to see with our eyes. So the idea for the HIPEC, the chemotherapy bath, is to try to disrupt or kill those tumor cells before they can implant and cause recurrent tumors. These are some of the chemotherapy drugs that are most commonly used especially for colon cancer and then gastric cancer. The idea behind the heat, you may ask why heat? The idea is that it kind of increases some of the penetration of some of these drugs. There's been a lot of thought on these drugs and their size and how much they penetrate and go in. And so balancing that versus getting into the systemic bloodstream. So I mentioned earlier this blood or this plasma peritoneal barrier, which was kind of hindering things from going from the bloodstream into the peritoneum. But in this case, we use that to our advantage a little bit. And we try to give slightly higher doses of this chemotherapy because now we know that it's not perfect. Some of it may get into the systemic system and cause potentially some side effects, but not as we can use higher doses. It's not as high a rate. And so we're kind of maybe using that barrier to our advantage to sort of keep it in the peritoneum rather than giving it in the bloodstream where it would go everywhere and be a little bit more toxic. And so then I just wanted to reiterate that the two go hand in hand. Removal of all visible tumor is pretty critical for HIPEC, because if you're leaving a big tumor behind, the HIPEC is probably not going to penetrate, an inch or two deep and be able to kill all that tumor. So it's really, they both go hand in hand, and I think are important aspects of the surgery. So early on, kind of in the early 2000s and 2010s, there was a lot of data in terms of what chemotherapy was best. And I pulled two studies here that essentially have opposite results in between two different types of chemotherapy, one called oxaliplatin and one called mitomycin. One showed that one was better and the other showed that the other was better. So this was something that we were trying to figure out. And we were also trying to figure out, does the HIPEC for colon cancer actually add something, or is it really just the removal, kind of the cleaning up of all the visible tumor that's really helpful? And so that's what this is the kind of really the other landmark study in HIPEC surgery and peritoneal surface disease was called Prognosis 7. This was also done in Europe, and it looked at just the cytoreductive surgery, so just that first part, versus cytoreductive surgery plus HIPEC. And I mentioned that there was a little bit of controversy about what chemotherapy to put in the HIPEC, because they chose a regimen they used oxaliplatin. And they also did somewhat of a short chemotherapy perfusion. And this show, you can see in these lines that there was actually no difference between the two. But some of the other take-home points were that this overall survival for peritoneal metastases from colon cancer was higher than some of the historical, known averages for just chemotherapy alone. So I think it highlighted that cytoreduction part is really important. And the question that it didn't answer, so I think it showed people don't really do HIPEC with oxaliplatin for colorectal cancer anymore. But the question that it didn't answer is, does the mitomycin C HIPEC work? So we still often will, for certain patients, use that for some patients with colorectal cancer. You can still do HIPEC, but the question is kind of the drug. And so we use mitomycin C instead of oxaliplatin. But this is another kind of landmark study, I think, that showed that there's still a benefit for appropriately selected patients for this kind of surgery for peritoneal metastases. So then what about gastric cancer, stomach cancer? This was one of the earlier kind of studies by a famous HIPEC surgeon. And what he showed is that for patients that you're able to fully cytoreduce, so get the tumor down to where we can't see anymore, they had the best survival. And compared to controls for patients with gastric cancer, or historical, kind of the average, similarly to what I mentioned earlier for colon cancer, but compared to the kind of historic averages for chemotherapy alone, if you were able to get rid of all of the tumor with the cytoreduction, the patients did pretty well with stomach cancer, relatively speaking, at least. And so this was also true if they had kind of less disease burden. So they had a lower PCI, so a lower amount of disease. Those patients were actually there. You can see that there are some survivors out here several years later. And so this was one of the early studies that showed that this was a promising therapy. Again, in selected patients, I think patients that have a high amount of disease and you're not able to get rid of all of the tumor, didn't really have that same benefit and kind of only were exposed to the risks of surgery. So with the right patients, there can be a benefit, though. And so similar to when we asked the question about does the HIPEC add something, I think that the data is a little bit better for stomach cancer, that the HIPEC does add something in this case. This was a randomized controlled trial, again, out of China, that was looking at, in the yellow, the cytoreduction alone versus the cytoreduction plus the chemotherapy bath, the HIPEC. And those patients did better with the HIPEC. And then similarly in Europe, this wasn't a randomized controlled trial, but they did some statistics and sort of matched the two groups up as best as they could. Outside of a trial, I think that was a pretty good way to look at this. And they looked at the cytoreduction alone, just that part of the surgery in red, but the HIPEC for stomach cancer, I think, added something. So kind of putting them together, I think that the cytoreduction and the HIPEC for gastric cancer, together, I think they show a benefit compared to cytoreduction alone. There was another trial here that was done looking at this, and another kind of HIPEC regimen looking at the cytoreduction surgery versus plus the HIPEC versus alone. So these are hard trials to do, and recruitment was slow in this case, and so the trial had to be stopped. And what they didn't see a difference in survival between the two groups, but they did show less progression, or a longer time before any kind of progression happened. It was twice as long in the HIPEC group, and so maybe the survival benefit didn't materialize because it was stopped early and there were too few patients. But I think this improved time before any kind of progression happened was encouraging still, even though the trial was kind of incomplete. And there is one more other trial that's kind of ongoing, or at least the results are still pending. They haven't been published yet, called Periscope 2, again, looking at stomach cancer and kind of evaluating HIPEC surgery. So all in all, I still think, even though I still think that HIPEC is with cytoreduction can benefit patients selectively with gastric cancer, stomach cancer. So I talked a lot about colon cancer, colorectal cancer, and gastric cancer. So there is one other kind of entity that I think really benefits from cytoreduction and HIPEC, and that's what we call low-grade appendiceal mucinous neoplasms. So oftentimes this is different from appendix cancer. Appendix cancer, although not quite the same, not really the same as colon cancer, is often treated similarly to colon cancer. But in the name, you notice that this isn't a carcinoma, this isn't a cancer, this was just a neoplasm. So these are known for making a lot of mucin and causing a lot of kind of gelatinous buildup of mucin in the abdomen. But you can tell because it's not a cancer, it doesn't have a propensity to spread or go to other organs. And it's also very low grade, meaning it doesn't divide fast. It actually divides very slowly, and it kind of is, it just sort of grows and pushes over time, and can certainly cause symptoms because of the buildup of that mucin. But these patients, I think, are really good candidates generally for cytoreduction and HIPEC. This is from Sugar Baker. He publishes, and what I'm going to highlight here is this: the x-axis here is in years. So a lot of the earlier ones were months, or maybe like going up to 3, 4, 5 years. But this is going all the way up to 35 years, and you have really long-term survivors, 10, 20 years. Most patients are still surviving after cytoreduction and HIPEC for this. And that's just because it's a low-grade kind of non-aggressive disease that doesn't really respond to chemotherapy because the cells aren't dividing fast. So chemotherapy doesn't really affect it, but can be really addressed with surgery and can have really good long-term survival and outcomes. So that was one other thing I just wanted to mention in terms of the indications for cytoreduction and HIPEC. So putting it all together, I've mentioned this a couple of times, but I really think patient selection is key for this. It's oftentimes a very large operation. It can last, 10, 12, 14, 16 hours sometimes, if there's a lot of disease, and we're stripping off, the peritoneal surfaces. Kind of imagine kind of trying to strip off all the wallpaper from the walls of your house. And so it's a large operation, and I think being medically fit is important to be able to tolerate that. I've mentioned a couple times, ability to remove all visible tumors and still, leave behind, the organs that are essential for functioning, obviously. One of the common reasons we can't do it is because all of the small bowel is kind of involved. And if we were to remove all of the small bowel, then it's impossible to get nutrients or eat. And it's just too much to be able to do. And so the disease burden has to be at a level where we can kind of physically remove it all. And then we're oftentimes thinking about what is the biology of this cancer, what's the prognosis. So that's what I mean when I say what kind of cancer. Is it that low grade appendiceal, not growing fast? kind of cancer? Did it show a response to chemotherapy? We generally think of those as having good prognosis. And so overall, with all of that, I think what I'm trying to kind of describe or mention is that we're really balancing the risks of potentially removing multiple organs and a long surgery, you know, sometimes a long hospital stay, and just a big recovery after a big physiologic insult and impact on really the quality and the length of life. And, you know, if you're in the hospital for 3 months, but we only increase survival by a month or two, you know, I think maybe that's not the best option, because there's a lot of that we want to maximize the quality of life as long as prolonging in the length of life. And so it's a really complex decision making that I think, at least in our experience, we try not to make in a vacuum. We make it in a multidisciplinary discussion and on an individualized basis. But those are some of the reasons that someone might be a good candidate, or you know, maybe there are other options that are better for them with respect to HIPEC treatment. So I also wanted to mention, you know, when I've been talking a lot about life prolonging or potentially even curative intent treatments, but palliative procedures and palliative operations for quality of life, I think, are also important. What we do know is that for people with metastatic disease or stage 4 disease, removing the stomach with the primary stomach cancer, or the colon with the colon cancer, and not removing all the rest of the disease is probably not beneficial. It's just, again, kind of exposing to the risks of that kind of surgery and the changes in the lifestyle after that kind of surgery without longer survival. However, I think some of the complications of peritoneal metastases, like ascites buildup or blockages, sometimes we have some options that are a combination of radiation, endoscopic options, chemotherapy options, or even surgery. Some of these might be necessary, and with the goal of alleviating specific symptoms rather than prolonging life. And I still think that that's an important part of the total care of patients with this disease. So that's, you know, kind of where we're at with respect to peritoneal metastases. But when I think about the future, I kind of go back to this paradigm for colon cancer, and I think about where we've been and where we come, especially in particular for liver metastases. So that was a common site of metastases. And I think a lot of work has been done to really improve survival and outcomes for patients with liver metastases. When I think about stage 4 or metastatic colon cancer, when you go back into the 70s and 80s, it was really just supportive care. So it was pain control if you had pain, or nausea medicine if you had nausea. But the survival was probably less than 6 months back at that time. The first chemotherapy that was shown to be, more effective than that was in the 90s. This was called 5-FU and leucovorin, that improved survival compared to just supportive care alone. And then, so people kind of started to think, if 5-FU and leucovorin work, what if we added another drug? So Folfox and Folfuri, that's 5-FU and leucovorin. That's the Folf, basically, that's common in both of these. And then the other drug is oxaliplatin or irinotecan. So these are triplet kind of regimens. And that improves survival a little bit more over what it was in the 90s and the kind of the 2000s. And then we developed more and more kind of chemotherapy. So things like targeted therapies and biologic, like bevacizumab or Avastin, or putting all 4 of the drugs together, which is a hard regimen, but continue to kind of push that needle forward. And so as the chemotherapy got better, we had response rates where the liver metastases were getting smaller and smaller, and going from an area of, I think doing surgery is too much and you won't have enough liver left, to now we can potentially take those out. So we've had to have a lot of different tools in the toolbox. I like this analogy that this group kind of came up with, being a Swiss Army knife for liver metastases. So you can do things like, take out chunks of the liver, do resections for little parts of the liver. You can take out a side of the liver and take out parts of the other, and take out just parts of the other side, leaving enough liver behind. You can burn parts of the liver. You can combine all these things together. You can do it in 1 stage or 2 stages. There's things like Y90 or radiation that are potential options. And then interestingly, there's something called hepatic artery pump infusion therapy. So that's where we put a catheter in one of the arteries that gives blood supply to the liver. And we can give chemotherapy directly to the liver without it going into the systemic circulation, the full body circulation. And if that sounds kind of familiar, it's similar regional kind of technique to HIPEC surgery for peritoneal metastases. And so I think that a lot of progress is made, and it's really moved the needle in terms of survival for patients with liver metastases. And when I look forward, I think there's a lot of work to be done to try to get to that level for peritoneal metastases. So this is one trial out of MD Anderson in Houston, where they took people with stomach cancer, and if they had at their initial staging evidence of peritoneal metastases, whether it be actual tumors or cells, you could do laparoscopic HIPEC. So not doing the cytoreduction, but laparoscopically placing the catheters and doing the HIPEC over a couple of different procedures. And some of them had that peritoneal disease go away and had their stomach, be able to remove that primary tumor, be able to remove. And so there were a couple of complications that happened, but it showed some relative safety of that, and that was maybe a paradigm that could be further investigated. A lot of these trials are phase 1, phase 2, so they're early phase. They haven't kind of hit mainstream yet or standard of care, but they're compelling trials for kind of treating patients and seeing what we can do to reduce that burden of peritoneal metastases, peritoneal disease. Another ongoing trial at UC Irvine, it's called STOPGAP. It's essentially putting in an intraperitoneal port or an intraperitoneal catheter for patients with peritoneal metastases from gastric cancer. And it's using NIPEC, so normothermic, not heated, but normothermic intraperitoneal chemotherapy. Giving giving the IP, the intraperitoneal chemotherapy, or if they're having a good response and the PCI falls, maybe going with a cytoreduction, full cytoreduction and HIPEC. And so this is ongoing. This hopefully will have once this trial is complete, some information there. A third modality for giving intraperitoneal chemotherapy or intraperitoneal targeted drugs is called PIPAC. So that's pressurized intraperitoneal aerosolized chemotherapy. And that's using laparoscopy and using the pressure of the laparoscopy in order to inflate the abdomen. We use 15 millimeters of mercury of pressure to inflate the abdomen, and then aerosolizing chemotherapy and using that pressure kind of inflation like a balloon to try to deliver the chemotherapy that way. And there's been several studies in Europe that I think in summary show relative safety of the procedure. I think it's hard to judge the efficacy because a lot of these studies included multiple different types of cancer and used multiple different drugs, but it showed that patients were able to go a couple of different procedures. And then the grade 3 adverse event rate, so it goes from 1, meaning relatively minor, to 4, meaning on the more severe side. But very few, kind of rare grade 4, the most severe complications, and maybe 1 in 6 had a grade 3. So I think that showed the general safety of this, at least in Europe. And then where I trained in Southern California at City of Hope, where they're investigating PIPAC with a couple of other centers in the US, but they're kind of leading this PIPAC trial in the United States. So that's where I trained, and I was a part of this trial using oxaliplatin as the drug and PIPAC for colorectal and appendix cancer. And this is phase 1, so again, we're just demonstrating safety and feasibility, but most patients were able to undergo more than 1. And of these patients, of whom I would say have had a lot of chemotherapy before. They're on their 2nd or 3rd line of chemotherapy. So we know that these chemotherapies are, we're kind of getting to the 3rd or 4th line chemotherapy. But in this patient population that's been pretty resistant to most of the chemotherapies. Half of them had their disease at least be stable or actually improve. And again, only one grade 3 complication of pain from the procedure. So showed safety and feasibility, and I think that there's potential future for this kind of delivery of chemotherapy, in addition to figuring out what type of chemotherapy is the best. This one was oxaliplatin, but I know they're also investigating mitomycin C. So a lot of work to do to figure out which delivery system is the best, and then which drug is the best. And so also one of the studies that I was interested in recently that I did was looking at the immune kind of response in the peritoneum. And what this study that I did showed is that a certain type of immune cell called a macrophage. So these macrophages are cells that kind of patrol their environment, and you know, if they find something foreign, like a cancer cell that doesn't look normal, or a bacteria or something like that, they generally tend to eat it, process it, and then present those kind of proteins to other cells to say, hey, look out for this, you know? So that's one type of macrophage. And the other type of macrophage tends to quiet down or slow down the immune system. It's suppressive, immunosuppressive. And that's to prevent the immune system from going haywire and causing kind of autoimmune or inflammatory, you know, side effects the other way. If you're trying to find a balance where you want the immune system to clean up and find abnormal cells that could be cancer, but you don't want it to attack normal cells. And so ideally this lives in an equilibrium, but what we showed in this study was that having more of the immunosuppressive, those quieting down, tamping down macrophages floating in the peritoneal fluid in patients with gastric cancer, we found that that was prognostic or predictive of worse survival. And so to me, that makes me think, is there a way that we can change these macrophages back to their inflammatory type? If they're associated with worse outcomes, you know, is that an opportunity for a possible immunotherapy in the peritoneum? And, you know, I don't think it's just me thinking of this, but I think that, you know, when we think of what drug to give in the peritoneum, I think we should be open to all of them and not, you know, solely chemotherapy, cytotoxic drugs, but maybe immunotherapy or even targeted drugs. So I would like to see in the future that we become Swiss Army knives for peritoneal metastases. We already have systemic chemotherapy. I think the medical oncologists do an excellent job delivering that, and they're constantly looking for new targeted therapies, you know, individualized therapies for specific mutations and things like that. And immunotherapy has revolutionized the way that we see cancer, and I think is going to continue to evolve. We already do surgical resection and HIPEC for peritoneal metastases, but some of these regional therapies, whether they're delivered by laparoscopic HIPEC or NIPEC with a catheter, or PIPAC, you know, or maybe a combination of all three. I think that's where the Swiss Army knife comes from, and having different tools, I think, is going to be hopefully excited, and there's a lot of room for growth and really moving that needle there. And whether we give chemotherapy, not only the method of delivery, but what do we give, chemotherapy or immunotherapy? A lot to sort out in the future, but I think a lot of progress that can hopefully be made. So that was what I had to talk about, past, present, and hopefully future. This is the French Quarter here in New Orleans and University Medical Center, where Dr. Moaven and I work. This is my contact information. Thank you all for your time and attention, and I'm happy to take any questions.
Dr. Sullivan, great presentation. There are a few questions coming in. Number one, what are the typical symptoms of peritoneal metastases?
Yeah, I think one of the early ones oftentimes is kind of changes in appetite or changes in diets. If you can imagine some of the peritoneal metastases, you know, lining the walls of the abdomen and potentially landing on the intestines, it can make it harder for food to move through. So that might be one thing that people might feel. If you have tumor that's growing or fluid that's building up, you can have kind of abdominal fullness or distension, bloating, and things like that. And that would also happen if things are slower to move through, causing nausea and things to back up, kind of changes in bowel habits. And then I think general things that happen to people with cancer are things like weight loss, fatigue, and things like that. I think that those are the kind of a lot of the symptoms that I think of when I think of this disease.
You spoke of gastric cancer, colon cancer, appendiceal cancer. What about pancreatic cancer?
So pancreatic cancer right now, we haven't shown a benefit for doing cytoreduction and HIPEC. I think that right now chemotherapy is the best therapy that we have for peritoneal metastases from pancreatic cancer. But I think there are potentially some trials out there. I do know at City of Hope in California, they were looking at PIPAC for peritoneal metastases from pancreatic cancer. So potentially on trial, some of these regional therapies might be an option, depending on the indications and stuff for trial, but currently not standard to do HIPEC for pancreas cancer.
Okay. What are the most important factors to determine if someone is a good HIPEC candidate?
Yeah, I think it's a lot of factors. I think it's a fit, healthy patient that can undergo a big surgery like that. And then it comes down to what kind of cancer is it? Is it really aggressive with large tumors throughout, or is it maybe perhaps more limited? We use things like a combination of CT scans and images to try to get a sense of that. But oftentimes we actually have to do kind of a relatively minor surgery, at least in comparison with a laparoscopy, where we look and actually look at the surfaces with a camera with our eyes to determine exactly where it is and whether that distribution of the cancer is amenable to a surgery. Does it involve vital organs that can't be removed? Or if it involves some organs, is it things that can be removed, like, for example, the spleen? And so it's a combination of what kind of cancer is it, how healthy is the patient, and what's the distribution, what's the burden.
Another question coming in, is there anything patients can do in preparation for cytoreductive surgery and HIPEC?
Yeah, that's a great question. If you are interested in it and think you might be a candidate, or someone has said you're a candidate and you're getting ready, I think for me, the biggest thing is I encourage patients to kind of do what we call prehab. I think if you were going to undergo a marathon, most people would train for that marathon. And so patients undergoing a big surgery like HIPEC, I would say eat well, eat healthy, eat things like protein to really make sure your nutritional status is as optimal as it can be. And then you don't have to, run miles, but I think being active and, moving your body and making sure that your muscles and everything are in shape, your lungs and your heart are in good shape, even if it's just walking, daily and trying to improve how much you can walk. Those are, I think, the two biggest things that patients can control to prepare: the nutrition and their activity.
Another question coming in, if HIPEC had negative pathology, does it mean chemo killed all the cells prior to HIPEC?
Yeah, I think if I'm understanding the question, if somebody did HIPEC surgery and what they removed or during the surgery ended up being just kind of scar tissue or not having cancer. Yeah, I think that probably if you were getting chemotherapy beforehand, that's probably what happened. And I think that would be a good prognostic factor that chemotherapy worked on that tumor. I think that without knowing the details, that seems to make sense to me.
Can a patient go through more than one HIPEC in a lifetime?
So yes, actually, especially for Lamin. Lamin's probably the one that we do multiple, the low-grade appendiceal mucinous neoplasm. That's probably the one that we do multiple HIPECs for most commonly. I think there are some select patients with other histologies. It would have to be highly selective, again, low burden of disease, and things like that. But it is possible, I would say, yes.
It doesn't appear that we have any more questions coming in right now. Dr. Sullivan, I want to thank you for your time and a great presentation. And I want to thank our viewers for attending the Facebook HIPEC Facebook Live event. And again, you'll be able to view this on hipectreatment.com. Thank you again. Have a nice holiday.
Thank you very much. Thanks, everybody.